right, so welcome to our NCEC webinar. As I said, we'll be starting in about a minute as we are getting people into our webinar space. Okay, so welcome everyone to our webinar today for the National Center for Equitable Care for Elders on managing diabetes in older adults within a dental setting, a practical integrated care approach. Next slide, please, Juliet. So just a little bit about us. We were established in 2017 as a national cooperative agreement, now a national training and technical assistance partner. And our mission is to build strong and innovative, competent healthcare models by partnering with CHCs, PCAs, and FQHCs to provide quality and inclusive care for older adults. And so if you haven't visited us in our various formats, please connect with us in any of these ways. Next slide, please. So just a few reminders. I think we're all probably seasoned pros now with Zoom and technology and webinars, but we'll keep you muted to prevent echo and background noise, and you can use the Q&A or the chat box to ask a question during this session. And it is being recorded, and the materials will soon be emailed after the webinar. And at the end of the session, we'll also have a brief evaluation, and if you could fill that out as well, we would appreciate it. Next slide. So I'd like to introduce our two facilitators for today. Both are subject matter experts and leads within our National Center for Equitable Care for Elders. I forgot to introduce myself. I'm Christine Reedy. I'm the director of the National Center for Equitable Care for Elders, or NCECE. And we have Drs. Maria Dulce and Leonard Brennan, and both Dr. Dulce is a nurse by training. Dr. Dulce is a dentist by training. Both have done work in advancing issues, healthcare issues and system change related to older adult health. And so I'm going to turn it over to them because I know we have a really exciting presentation and discussion today, and I want to be able to give it its full amount of time. So please take it away.
Thanks, Christine. And I just want to say what a pleasure it is for me to work with Dr. Leonard Brennan, who is a dentist and a collaborator in so many different projects in terms of working together to advance oral health and improve oral health for all. And so I am delighted to have another opportunity today to present this collaborative webinar and to work with Dr. Brennan. So we're going to advance our slides, and I hope that you can use our chat box as we begin the program today. We would love to hear from each and every one of you about what you're hoping to gain from today's webinar. And towards the end, we can review your comments and make sure that we've done the best that we can to answer your questions and your expectations. So we'll advance to the next slide, which is the learning objectives for today's webinar. And at the completion of this webinar, we hope that you will be able to explain the value of utilizing the dental office for screening and monitoring diabetes, specifically in older adult patient population. Also, we want to talk about some of the obstacles and barriers and really identify strategies to overcome some of those obstacles and barriers for implementation and tracking. And then lastly, to discuss how we can promote a collaborative approach for hands-off communication and referrals for older adult patients, which is all about interprofessional collaborative practice. Advance. I did want to bring your attention to this, the work that Dr. Brennan and I, in collaboration with the National Center, we conducted a learning collaborative in the fall 2019 timeframe. And it was all about implementing blood glucose and hemoglobin A1C testing at the dental provider. It's broken up into 6 separate webinars and or components. And I just want to bring your attention to that. If you are interested, it's really a valuable resource. The contact information is at the bottom of the screen. Advance. I wanted to start out because the first objective is really to talk about the value, like what is the value of monitoring and tracking hemoglobin A1Cs and blood glucose in our dental patient population. But I think the elephant in the room is really about oral health value-based care. And so I want to start off with a definition of value-based care. And I'm going to read this specifically so that I am clear. So value-based care is considered a person or patient-centered approach to healthcare delivery. It's designed to improve health outcomes and lower the cost of care. And value-based payers reimburse providers based on the quality of care instead of the volume of care. So we're moving from the expectation is that we are moving from a fee-for-service structure to a structure where reimbursement is linked to quality and outcomes at the patient and population level. And it's really linked to the quadruple aim, which has been promulgated by the IHI, Institute for Health Improvements. And I think you're all familiar with this. It's improving the patient experience of care. It's about improving outcomes both at the individual level and the population-based level, reducing costs, and also to improve provider satisfaction. So again, this provides for me a framework for and a rationale as well as why we are doing the work that we're doing in terms of integrating medical and dental services within the dental office. And what we have seen most recently is that there has been a uptake or adoption of value-based care within medical systems versus our dental systems, which seem to be lagging, but the interest is growing. And in terms of value-based care, I would say that the focus shifts from treatment to prevention. The focus shifts more on collaborative practice and medical dental integration, and also really relies on having a robust infrastructure to manage health information technology. Please advance the slide. And so this is really a great depiction, and I have the source of this diagram at the bottom. It's through the DentaQuest Foundation and the National Association of Community Health Centers. It really just illustrates the difference between the traditional dental care system and what I guess we are moving toward. That's the expectation, that we're moving towards a value-based care system. And again, it's about prevention, it's about medical dental integration, collaboration, interprofessional communication, cross-referral systems, robust electronic health records or systems for that. And really a personalized care approach, very much a person-centered care approach. And we have an esteemed guest speaker later that I will introduce. And I think she will really afford us basically a bird's eye view of what this might look like for the future. Next slide, please. So in terms of not only value-based care, but looking at collaboration between medical and dental providers and really keeping the patient at the center of care. This diagram, which comes out of the evidence-based standards for medical care in diabetes, talks about really at the center is the patient and the goals of care, and that is to improve outcomes, prevent complications, optimize quality of life. And it's about having really an interdisciplinary plan of care, which really calls upon all of us as providers and as a health system or organization to really think about our patient and putting that patient at the center. Next slide. And I think we will be moving forward. I would love for Dr. Brennan to now take over and really give us sort of an overview from a clinician perspective about diabetes and oral health. Thank you.
Thank you. Going back on one of the statements on that, the slide on the oral health value-based care, that was a great slide. As a private practitioner for 40 years, getting paid for value versus procedure is really quite controversial on how you do that. And the implementation of that is difficult. It's like dentists and having their independent offices like to make those independent decisions. So that is an interesting conversation on its own. And I like the way you presented that, Maria. That was great. And Dr. Lay, I'd love to hear your input on that also, that value-based care versus strictly being paid to fix one piece of the car at a time. So maybe when we had a chance to chat, we can talk about that. On just an overview of the facts of diabetes and pre-diabetes in the United States, when we look at this as a whole, it really is overwhelming for me to get my arms around it and quite staggering. When we look at 30 million people with diabetes and the percent that don't know they have it, or the percent that have pre-diabetes can be 30% of the population. But when I take these numbers, really living in Maine, what do those numbers mean for me? And how do I use it in my practice so that when I leave a lecture like this, what is it that I want to take away? Well, in Maine, where we have about 1,400,000 people, what that means is 25% of our population may have diabetes, seniors. And when I look at that, what it means for me as a practitioner, that means I have to be looking at them not only from an oral standpoint, but from a total patient care concept, because 1 out of 4 may have diabetes or pre-diabetes. And if I'm serving my population well, I need to be looking at that dentally so that I can also deal with it medically. Next slide, please. As a dental provider, one of the questions I would always ask myself in the dental community, well, why us? Why the dental community? And why don't we refer them out to our colleagues? Does this mean more education? Do I have to train my staff? Am I going to get paid for it? These are the obstacles that we'll be talking about later. And also, what do we do from the legal standpoint of it? But it does make sense in a lot of ways, because diabetes is probably the most common chronic condition that we see in our practice. So think of that number, 25% of the senior patients walking through could have diabetes and definitely have other chronic conditions. As a dental practitioner, I want to know that number, because if I'm going to efficiently treat these patients for any type of inflammatory disease like periodontal disease, we have to make that connection that Diabetes is a risk factor for periodontal disease. Also, diabetes and periodontal disease has a bi-directional relationship, which we'll talk about later. They go hand in hand. And the other, which is really important for us to realize, especially in the older population, we may see some of these older patients for a dental visit more frequently than our medical colleagues. And that's a very important piece to put together on this puzzle. Next slide, please. On this slide here, there's just a couple of points. It says nearly 28% of people with diabetes may not be aware of it. And connect that back to the last slide where some of our seniors are coming into our dental office. We may be that point person. And on the last point on this slide, dental screening and monitoring in the dental office can improve our patient care coordination. So it takes us out of the dental office. So if we can be aware that this can be an issue, and then we have the eyes that can see it medically, then we have the ability to use a coordination model to refer to our colleagues. Next slide, please. When we look at this slide, I want to look at it from a siloed approach first. As a dentist, somebody comes in and they have red swollen gums, bad breath, and everything on your left side. Well, I could treat that in my silo dentally. But if I don't step back and look at that total patient picture, then I'm missing a lot. Because anything that I do to treat the periodontal disease, if I'm not looking at the total patient, I'm missing the fact that is there thirst issues and hunger issues and urination issues. And if it's only siloed and I'm only looking at that, I'm only looking at one piece of the puzzle. And again, when I'm looking at the population in Maine, if I'm looking at only on the periodontal piece, and I'm not seeing that 25% of my patients could potentially have diabetes, I'm missing a very large piece of this puzzle. And I think we have to keep that in mind because it's very similar throughout the United States. Next slide, please. In the dental office, we have a unique opportunity to be able to sit so close to our patients and look at and talk to them about smoking and other issues that they may have. And many of these same risk factors that affect periodontal disease, they also affect diabetes. So we are in a very unique position, not only in terms of close proximity to our patient, but also overlapping the health, the dental and medical health portion of their health history to really be aware of a patient as a potential diabetic. But to be there, we have to actually think that it is part of our ability to see it, because if we don't see it or think about it, then we won't be able to diagnose it or manage it. Next slide, please. Over the last few years, there's been so much information that has been released on the connection between gum disease, periodontal disease, and diabetes, and vice versa. This is a very important slide because it really shows that if you do not treat periodontal disease, it's more difficult to manage somebody's glycemic control as a diabetic, and vice versa. So they are interconnected. And when we look at a patient, we have to look at the overall picture that they are connected. We are more than just a mouth. We are part of the entire system. It's really important for our colleagues, our medical colleagues, to also be able to look at a patient and say, we can't manage you well or as well as we would like unless we look at your oral history and periodontal disease. So that connection is very important. There's good information on the slide, also some data you can look up. I accessed most of this data, so it's up to date as of November 2020 on all the slides. Next slide, please. But again, what does this mean for us as dentists and patients, but also for the healthcare system? And one of the things that's coming out, this is a study from 2014, really most of the studies will show that if you're treating gum disease, it can mean lower medical costs and also lower admissions to the hospital. This is a slide that you can access. It's worth accessing And also the learning collaborative is worth accessing on these points, because there's other slides that can direct you to other information. It's a great slide. So we are connected. Next slide, please. This is a test, I think, as a dentist, we should all have them in our office as part of our health history. It's from the American Diabetic Association. There's 7 questions you can ask a patient. You can scan down the results. You can take a step back and say, we need to have a conversation. Your results are pointing towards something that may be pre-diabetic or diabetes. And it's such a simple test, but what it tells the patient is that we're looking at them more than just teeth and gums, that you are an entire person. So it's an easy test, it's quick, it takes just a second, but it's very valuable. Next slide, please. Next slide, please. So the only point in this slide that I think it's important to bring out is that screening for diabetes and prediabetes, it is feasible in a dental office. And next slide, please. When we look at these obstacles and barriers, I look at these, my obstacles and barriers, and Dr. Lay will actually be discussing these from a personal standpoint. But we're more than just doctors of the teeth. But with technology today, we are becoming more technicians than we are oral doctors. And so it's important that we take a step back and make that connection to oral health and not just to some type of new technology. Next slide, please. The stumbling block that we hear when we give any of these learning collaboratives or webinars, it's the scope of practice laws, and they are obstacles. And we have to deal with them individually in every state, as Dr. Lay had to deal with them in her state. So we'll be chatting about that. Very important, it's on everyone's radar and people are looking at this. Next slide, please. Reimbursement. You know, Dr. Donovan, who was the past dean at Harvard, always said that voluntarism and free service is not really a sustainable a point of care, and it really isn't. So if the dental providers need to be reimbursed for their services, how that comes about is going to be a process, but it's one of the obstacles for sure, and it was in my private practice. Let's go to obstacle 4. Next slide. And let's just, there we go. And the other part is, I think, dental buy-in. Dental providers must understand the rationale that we just talked about. Why is it so important to identify their patients, then to screen them? We're not diagnosing. We're sending them to the medical colleagues for the diagnosis, but we are sharing our information. So the dental buy-in is very important. Next slide, please. But what we have found is that the patients, dentists, and physicians are all willing to be part of this team. From a patient standpoint, it absolutely is more convenient. It saves time, and it provides other healthcare information. But everyone generally is on board. So we're there in that standpoint. Next slide, please. Maria?
Brennan, yes. Yeah, this is really just a placeholder here. I just wanted to, I think it's so self-evident about the importance of interprofessional collaborative practice in terms of improving patient outcomes, and that our care should be person-centered, team-based, the importance of medical dental integration and interprofessional communication, and et cetera. So it's why I have it here is to let you know that as we have a conversation with our esteemed guest in a few moments, I think that you will see illustrated in some of her stories and examples of clearly the importance of this interprofessional collaborative practice and these elements of being team-based, being person-centered, the integration between medicine and dentistry, and the essential importance of really effective communication. So we could kind of go through the next 2 slides. I'm going to skip them if you could advance. It's again about team-based approaches and also collaborative practice is a key core competency. HRSA had set out, and I think most of you know, set out a set of competencies for primary care providers related to oral health and primary care integration. And again, collaborative practice is a key competency domain. We did list a few evidence-based resources for you after today's session to take a look at to help you implement some of what you've learned today. So the next slide, and it's my distinct pleasure and privilege to introduce Dr. Woon Lei. Dr. Lei is Chief Dental Officer of Asian Health Services located in Oakland, California. She's a member of the Board of Directors of Western Clinicians Network, Alameda County Dental Society, NACHC Clinical Practice Committee, and Health Policy Committee. She just finished an 11-year tenure as board member of Dental Board of California in January 2020, where she served in various capacities, including president, vice president, and chairs of various committees. Interestingly, Asian Health Services has a very robust integrated care model, including depression screening and diabetes screening and testing. Her depression screening innovative approach has been recognized by HRSA as a best practice and featured in several newspapers. During COVID-19, Dr. Lei implemented very successful telehealth and drive-through fluoride varnish programs at her health center. Her post-COVID reopening plan has been shared at the local, state, and national levels with safety net clinics and private practices. Dr. Lei has faculty appointments at several dental universities. She began her 3-year leadership fellowship program at Northwestern University in December 2019, which was sponsored by the American College of Dentists Foundation. Dr. Lei is a fellow of the American College of Dentists, Pierre Fauchard Academy, and International College of Dentists. In May 2020, Dr. Lei received the Myron Alukian Lifetime Achievement Award presented by the American Association of Community Dental Programs. So please join me in welcoming Dr. Lei. And I am going to start off our conversation with the first question. So welcome, Dr. Lei. And we are so excited to learn about your experiences at Asian Health Services related to integrated care and innovation in the context of value-based healthcare. To start, please discuss the value of utilizing the dental setting for screening and monitoring diabetes for older adult patients in your clinics.
I have to unmute myself first.
Okay.
Well, first of all, thank you so much for the opportunity to share with you, our experience at Asian Health Services, and thank you very much for the kind introduction. Everything that you presented in your PowerPoint presentation rings true to the experience that we have at Asian Health Services. We believe, I think a lot of us dentists think that we are dental surgeons. We drill and fill. And so we practice in silos. Well, the good thing about practicing in community health centers is that we do have other departments, working alongside with us, and that's the medical, behavioral health, specialty mental health, and other departments. So I have always advocated that we dental providers are not just dental providers. We are part of the health care team, at the health center. So what that means that when we see a patient, our patient is a mutual patient between medical and dental and other departments. So we have to take care of the patients as a total person and not just looking at the teeth only. So we we are very, fortunate that we have been able to get the buy-in, from all departments at Asian Health Services. It wasn't easy, but we were able to overcome the barriers and challenges. Um, so, with so I like I said, you mentioned with the triple aim how the value-based care really shifted from treatment to prevention. And I think that's exactly why we decided to do the integration of behavioral health and also diabetes, because we do believe that, by doing this, we are able to capture or at least identify patients at risks that may have been missed by other departments. And I have some stories to share with you later on.
Thank you.
That's great. Thank you very much. On the value-based care, just to kind of follow up on what you were just discussing, on the value-based care in the community, the private practitioners, have you had feedback from their standpoint on their acceptance of a value-based care system?
I was in private practice before I entered, the public health. I have a lot of colleagues, although I've been in, community health center for over 30 years. I still have a lot of colleagues and also family members who are in private practice. And, I do think that they all understand, the issue. They all understand that our patients do have medical issues that will affect the treatment plan, so they want to be, part of the healthcare system. They are slightly behind, I believe, in adopting the value-based care. And I think it probably has to do with the reimbursement. They probably don't have the workflow, figured out yet. But I do think that I am seeing a trend towards providing more comprehensive care in even, practice, from my conversations with my, colleagues and also my family members who are dentists. By the way, we have 10 dentists in my family, so.
Well, that's very valuable because you have a foot in both worlds, and
Yes.
I knew that you did. So, I mean, that is what we see today, and some of our learning collaboratives, that was one of the questions that occasionally would come up is, what is going to happen to my private practice? How does it make my patient's life better? And you really kind of represent both those worlds and can show us what comes out of that. So that was terrific. I have a question on if you could share a story on that illustrates that bi-directional relationship between dentists and our medical colleagues, because it sort of puts together the fact that there's collaboration, there's communication, that we're talking to each other about both the medical and dental aspects. And would you have a story that you could share with us concerning it?
Yeah, sure. About a year and a half ago, I wanted to start doing the A1C testing, in dental office. So, and so we've been doing the behavioral health integration for about 5 years now, and it's been very successful. We've seen a lot of, patients who, who have had problems with, with their periodontal, disease. Even after the periodontal therapy, the conditions didn't improve as what we hoped to see. We have patients who also show up with delayed healing post-extraction. So a lot of these patients, we have mutual patients, so we can actually look into their medical chart to see whether or not they have a diagnosis of diabetes. And interestingly, a lot of these patients don't have a diagnosis of diabetes. So we thought to ourselves, okay, these patients have very high BMI. They have high blood pressure, and some are actually on blood pressure medications, yet they don't have a diagnosis, of diabetes. So we thought, well, maybe they are they just don't know, or maybe their PCP, has not done any evaluation on diabetes. So I went to my, medical leadership team to talk to them about what I wanted to do, and that was to do with A1C testing in dental. And I met with some resistance. Really the first question was why? Why do you want to do this? We're already taking care of our patients. Why do you want to do this? So I had to explain to them, some of these scenarios that we've seen, delay healing, advanced periodontal disease, and not being responsive to the treatment that we provided. And we actually have periodontists, specialists on our team. So, and so, and also I had the data to show them that a lot of these patients, although they're mutual patients, medical and dental, they were not seen by medical, for a while, but they've been coming to see us in dental several times in a year. I also found out that our medical counterparts do the hemoglobin A1C test every 6 months instead of every 3 months. Also, one of the reasons for them to start doing the hemoglobin A1C test is if the sugar test at that particular visit is high. But if the sugar test, if the patient's blood sugar is reasonable at that visit, then they don't go further as far as testing. And I thought it was really interesting. So anyway, so I just explained to them, I said, okay, you do hemoglobin A1C every 6 months. The recommendation is 3 months. So if the patient come in, between those times, and if we see that the last one was done over 3 months ago, we could definitely offer that in dental, and we don't have a problem with that. So then, as the conversations went on, then they said, well, we have a lot of slots in nutrition department. So if that's the case, we will so they wanted me to actually refer pre-diabetic patients to nutritionists because there were, appointment slots available. So it was really interesting, that started out as why you want to do it, to, well, how about you help us fill those slots, and then, and basically they said, okay, if the hemoglobin A1C is at a certain point, then we would like for you to refer to us. Otherwise, just refer to nutritionists. So the buy-in went on, slowly, but it did happen. On the dental side, though, it was easy. My dental providers have been wondering why these patients are having these complications, and the patients don't have a diagnosis of diabetes. So they do want to know why, so the buy-in on the dental side is easy. The buy-in on the medical side, was a little bit, challenging, but we were able to overcome the barriers. So during the pandemic, at one point in time, about 75% of my physicians were actually working from home. It's been going on since March. So you can imagine that these patients, although could see the physicians, talk to the physicians, but just through telehealth. We're still seeing patients in dental. So I can share with you a couple of stories. So like in September, we had an elderly patient that came in for dental. Her blood pressure, according to her medical charts that we could access, showed that she was seen in person in January 2020. She had 2 telehealth visits in April and June. The record showed that she self-reported now, her blood pressure was 134/85 for both visits. And that's what the PCP recorded. Well, we saw her for emergency dental visit, and her blood pressure was 185/115. And we took it 5 times over a period of 20 minutes, and it was still high. So it's not white coat syndrome anymore, after 20 minutes. So anyway, so then, we had her, well, the way we work is that we have all of the patients 18 and older fill out the American Diabetes Association diabetes risk survey that you showed, in your PowerPoint presentation. And if they score a 5 or higher, then we would offer the hemoglobin A1C test. So she did score a 5. So we took that opportunity to talk to her about her condition. The fact that she also was not compliant with her medication. She was on 2 medications for blood pressure. She decided to just stop taking one of them because she said her blood pressure was 134/85. So that was good enough for her. So she decided to just stop on her own. Her PCP did not know that. She told us that. So we offered the A1C. Her A1C came out to be 6.5, which is basically put her in the condition of diabetes. She had no idea. So because of that, we were able to refer her to medical for further evaluation. As you said earlier, Dr. Brennan, we are just screening. We are not diagnosing. And that's what we told her. So we screened, your A1C is 6.5, which is in the range of possible diabetes. So we would recommend that you go see your physician. So what happened was she was scheduled to see her PCP on October 1st. Well, we found out that her PCP was going to work from home. So it would be another telehealth visit again for her. And so we said, I stepped in. I said, no. She is going to be seen in person by someone. It doesn't have to be her PCP, but by someone, because I really wanted her to be evaluated for not only her blood pressure medications, the compliance, but also for the diabetes. We had another oral surgery patient who's only 20 years old. And before, our oral surgeon worked on him, she decided that she wanted to test his A1C. Well, he did have a diagnosis of diabetes, but it hasn't really been followed up, as closely as it should have. So when we did the hemoglobin A1C, his was 10.7. He's 20 years old. So we referred to the pediatrician. The pediatrician saw him, did another A1C, and found that his hemoglobin was actually 12.0. So he was referred to an endocrinologist now. That's something should have happened some time ago, okay? But because we were sending the patient to the pediatrician, now this patient is in specialty care, as he should have been. And then just last week, we had another geriatric patient that came in. Her blood pressure was also extremely high, 209/114. And then another one like 218/107. Her BMI was 27. And she was also on 2 blood pressure medications. So, of course, when she filled out that form, she's never had a diagnosis of diabetes, okay, in her medical record. So we did the A1C, and it was a 10. Her hemoglobin A1C was 10, which is really considered as uncontrolled. So we referred to medical. They did the A1C there, and they came back with 9.4. Now there could be some calibration, in the machine. I mean, different machines could give you, but at least it's still in that same range, of not very good, diabetic condition. She never had a diagnosis of diabetes. Okay, just like the very first patient I shared with you. So, so again, the PCP sent her in for additional blood work, and we are waiting for her kidney function tests to come back, on creatinine and buyin and all that. So again, this is why I truly believe that it's so important for us dental providers to be able to do the screening on the patients. As you mentioned earlier in your PowerPoint, about, a huge number, like 25% or so of the US population are not even aware that they may be diabetic. Now, if we capture some of them, through just a very simple screening test, I think that we are doing a great service to our patient. I ran a very quick report just before I came on this webinar actually, and I found that in the first 10 months of this year. Now remember, because of the pandemic, our number of face-to-face visits, is very limited, right? Very reduced. And we had 37 patients that tested A1C in the dental clinic who are potentially diabetic. 37 patients that would otherwise have not known that they are diabetic. So, who knows? In a regular situation, non-pandemic, that number could be a lot bigger. So anyway, so I will stop here. And
I want to thank you because I just think you just summarized what Dr. Dalton and I just were discussing, but in the real world, value-based care, the rationale for dental care, you need to be aware of your patients, you need to be able to identify them and refer with good communication. I think that those stories put it all together. So thank you for sharing.
Yeah, and Dr. Lay, I mean, the stories just totally illustrate the point of the whole webinar here, and that is, what is the value of screening and monitoring diabetes in the dental office for older adult patients? So thank you for that. When I think about, we did mention the quadruple aim or the triple aim plus the quadruple aim for quality and patient safety. I think that goes hand in hand when we talk about value-based care, excuse me. And it also goes hand in hand with continuous quality improvement processes. So I would love to hear your experiences in your role at the Asian Health Services regarding CQI, and as well, maybe perhaps provide some examples about your experiences in developing and implementing protocols and new workflow processes in order to establish a new standard of care for your patients.
Oh, okay. So let me talk about the CQI thing first, okay? So we actually serve on the CQI committee for the entire agency, which is very, very helpful in that we share the information with all the departments. And interestingly, diabetes is one of the projects that after the last operational site visit, HRSA wanted us to focus on. So with that reporting, what happens is that we have we have 3 things that we have to report to HRSA, and one of them is actually the dental diabetes data. So with the CQI, we have found, for example, for the behavioral health screening that we started 5 years ago, for this year, because of the pandemic, medical side behavioral health screening has gone down significantly. Ours has actually gone up. So the contribution in that measure, depression screening for our UDS measure, dental actually contributed about 14%, okay, of the measure. And our goal is 75% of the patients have to be screened for depression screening. And we contributed 14% to that measure. Now, we are only doing the depression screening in geriatric patients. Medical does it for all patients. So you can imagine if we expanded our depression screening to all ages, I bet dental probably would have contributed a lot more than 14%. When it comes to diabetes, we have also done extremely well. In fact, because of our number of A1C tests, quite a few are below, which is good, below 6.5, but we also have quite a few that are above, and and quite a few that were undiagnosed. So I think that number has really contributed. I have not really run a report. My CQI director has not run a report, but at the last meeting that we had last week, I can tell you that my physicians, the medical leadership, was just in awe of what dental has been contributing. In fact, one of them even said, it's just amazing that you guys in dental are practicing in such a holistic approach. You know, that you are really taking care of your patients. You know, I mean, as a whole person, because we're recording BMI, we're recording immunizations, we're recording, you know, diabetes, you know, A1C, depression screening, and everything. So, so I think that, you know, I'm just dying to see what our contribution is for the diabetes, you know, but I know that the CGI director has reported to the whole group that we have done a lot. Like I said, you know, I think we've probably done, you know, I don't have my record here with me, but like I said, you know, I mean, every month, I would say that we do an average of probably 200 A1C tests so far, 200. You know, so that's quite a few, you know. And like I said, a lot of times, you know, before we, so now I'm going to go into the workflow, and that is every patient 18 years and older that comes to our clinic, when they check in, we have a patient packet for them to fill out. And that packet includes the medical history, dental history, of course, like, you know, financial and no-show policies, just a whole bunch of, like, you know, HIPAA, you know, and all that. But we also include the behavioral health screening and the diabetes screening in the packet. So when the patient comes in, they basically fill out everything. We have the diabetes screening survey translated into 3 different Asian languages: Chinese, Vietnamese, and Korean, because those are, like, you know, the most I guess, common, you know, Asian languages spoken by our patients. Of course, you know, our patients speak like 14 different Asian languages, but those are the 3 most common. So we did have it translated by our staff into those 3, you know, languages, and the same, you know, with our depression. Actually, our depression screening is translated into 5 different Asian languages. That being said, so everybody basically fills out the same form. You know, it's very easy, very simple. The patients just fill them out. They don't even think twice about it. They don't even ask, why am I filling out these forms out? The dental providers, you know, check those forms in the exam room, talk to the patients, and when they go through, and if they feel that, okay, you score a 5, they start talking to the patients, you know, about the A1C testing. And we offer it to the patients, to all patients. Now, if they don't want it, that's fine. We don't force them. If they score 5 or above, and they refuse, you know, to have the A1C test done in the dental office, then we would recommend that they go see their physician. And I must say that, I mean, it's been over a year and that we started this program. I would say we had a handful declined. And in fact, we had patients who score a 4. So we don't offer. They asked to be tested because they knew we were doing it. You know, so they score a 5, I mean a 4, so we don't offer. And then they ask, well, I heard that you do the diabetes test. Can I get it done? So it's really the word in the community, I suppose, that we do it. I don't know how they found out, but you know, and so I think it's really great that it happens. So when we do the test, you know, we enter that in our record, in our dental record. We have 2 different platforms. Medical uses Epic, dental uses Dentrix, but we do put the information in both. Okay, so we enter in Dentrix that diabetes screening was done, and if they didn't need the hemoglobin A1C, then it stays there. That's it. But if we did the test, then the numbers would be entered into Dentrix. We also put it in Epic, just so that the medical staff could see that A1C was done. And that way they don't have to do it again. You know, so that's the communication. So that's the workflow that we have. And I hope I answered your question.
Yes, you did. And Dr. Lay, I want to applaud you and your team in terms of really showing us how dental providers can effectively provide whole person care because that's, you know, hearing your stories, and that's what I am seeing. Unfortunately, we're running out of time. I'm not sure if there are questions that perhaps our audience might have, and we can have them enter the questions in the chat room. And while they do that, with the remaining time, is there anything most salient that you would like to share with us today regarding your experiences, regarding perhaps obstacles and barriers, or collaboration and communication?
Yeah. So, well, thank you so much. I know we went out of time, so I'll try to be brief. So, like, you know, when you talk to the medical counterparts, and if they say no, you know, don't stop there. Just keep talking. Work with them. Like in my case, you know, my medical leadership was worried that I would be sending mixed messages to my patients. So they said, well, we don't want you to be doing that. So I asked them for their protocols. I said, then please share with me your protocols, and we'll follow that so that our patients are getting the same message. If you're on different platforms, you know, for AHR, don't let that deter you either. You know, we're doing a service for our patients. And I think, as Dr. Brennan indicated earlier, we are not technicians, we are clinicians. And I think that's something we need to keep in mind. We are clinicians, okay? So we don't just drill and fill, okay? We are clinicians. And if we can take care of our patients, you know, let's try to do that. It's not that hard, and it's not that, it doesn't really take that much time, you know, out of our daily routines. But as you can see, those 37 patients that did not have diagnosis of diabetes are now in diabetic care. I think that speaks volume. And I think that we are really making a difference in those 37 patient groups.
Thank you.
Thank you.
We have about 2 minutes left. I'm not sure if our audience has any questions, but I know that as you think about what we presented today, and as questions come up, please feel free to email us. The email address is in the chat box for you to consider. We'd love to hear from you. We'd love to also hear about other ideas in terms of future programming. So on behalf of our team, I'm going to turn it over, thank everyone, but also turn it over to Dr. Reedy.
Thank you so much, Drs. Brennan, Bilche, and Lei, for having a conversation with us about what Dr. Lei is doing in her practice at her community health center. And I think that we've learned a lot of really valuable information today around some of the intricacies around doing this, as well as navigating some of the obstacles that might present itself. And so we're really appreciative of Dr. Lei and for everyone who attended. And again, we will have this presentation available, but please fill out the survey, as Dr. Dolce mentioned, and I hope that you all have a good rest of your day. Thank you so much, everyone.
Thank you.
Yeah, thank you.
Thank you.
Yeah, have a good day.
Bye-bye. Thank you.